So I was on my work the other morning, and there was an incident on the interstate that had backed up traffic horribly, and I was taking side roads, and I was in a hurry. I was in a bind because I was way behind, and I was looking to make a deal. No, that was a different situation. Never mind. Anyway, so I was getting a little agitated sometimes when probably not a good choice, but I like to throw on something a little bit heavy. Yes.
I raised my hand, by the way. Were you in Georgia?
No, that's why I changed the...
It took a while for that reference to hit me.
Right, and I'm assuming a lot of our listeners probably don't get that. Some will. Some will.
Devil went down to Georgia.
Mm-hmm.
He's looking for a soul to steal.
Who sang it?
A very good fiddle player.
As referenced in the song.
Well, okay. Fair enough. Oh.
That's right, Chris, the Charlie Daniels Band.
Yes. Yep, Charlie Daniels.
So anyway, I'm driving on my way to work. I don't know if this can be used against me in a court of law, so I'll just say maybe some borderline driving techniques.
Creative driving, got it.
Creative driving. And I was in a hurry and stuff like that. Now, one of my urges at these times, when I'm maybe a little bit frustrated, wanting to make some good time.
I like hearing about your urges.
is I like to put on maybe some heavy metal.
Yeah.
Right, because that's always going to improve the situation.
Jeez.
Is angry person, angry music. That always, I think it's like two negatives make a positive sort of thing.
Yeah, no, that's absolutely.
So, at a stoplight, I go through my phone. Little Guns N' Roses, Appetite for Destruction.
Good.
That should really improve the situation right here. So I put it on. It's not as loud as I want it to be. Using your on steering wheel toggle to up the volume really makes it feel a little less metal.
Oh, it's like, yeah, it's rock out.
Because there's a thing where you spin the dial and crank it up.
Oh, yeah.
Diggy, 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 diggy. It goes up in increments of one.
Yeah.
Yeah, it takes a little bit of the edge, and that's when you know you're getting old.
Crank it up to 11, Mark. Hang on.
Just a second. At 7, 8, 9.
It's going to be really fantastic, guys. Just wait.
It's coming. Here you go. Here
you
you
always
go.
feel like you should pause the song, crank it up, and then
Crank it up
play
and
again.
get back into it. Yeah. Hey, welcome to Medical Stuff. My name is Mark. I just took a blow to the head, Frankum, and that is Chris Perseverant Questioning Finkston right over there.
Ooh, perseverant questioning.
Big words like marmalade.
Yeah, we're okay.
Yeah.
Marmalade and perseverant questioning are not even related a little bit. Oh, I guess
They're both
they're
big words.
Big words. It's fair. Yeah.
Come on, man.
Hey, I had a beer. Come on.
And
we know I'm a light. We know I'm a lightweight.
Yeah.
You have beard. I have
you
beard.
are a cheap drunk.
Yeah, but I think that's actually an advantage. And when I was younger, it almost like bummed me out that I couldn't drink as much as everybody else.
Oh, now you're responsible for your own finances?
Yeah.
It's solid.
Yeah, I'm just like, oh, this is great. They're like, only 2 beers. I'm like, ha, it took you 7.
Right.
All right, that's today's episode. Go ahead and...
So today's episode is going to be on head trauma. So, strangely enough, we're talking about trauma to the head.
That's weird. You wouldn't have suspected by the title of head trauma.
Well, that's why I really wanted to give an explanation of it, so we were clear.
Yeah, no, I think it was actually fair to say that.
So let's start out with the anatomy of the head.
Yeah. So the head is located between your shoulders and just slightly. Well, so I was going to get a little more just between your shoulders and superior to your neck.
Well, it can't be both. Because if above your neck, it can't be between your shoulders.
Depends.
Unless you're shrugging constantly.
Yeah. See? Point, Chris. And I even folded my arms when I said that.
Mm-hmm. He tried to play that out.
Yeah.
So your skull. It's going to be the first thing we talk about. It's your bony protrudence at the top of your neck.
Oh, that's a protrudence.
It's up there with marmalade and perseverant.
Yeah. Oh, yeah. We're going to talk about perseverant later on, too.
Yes, we are.
Yeah. So the skull, it's a funny little bone. And when you're born, it's actually not well, it's actually several bones.
It is.
And when you're born, it's actually not fully formed. It's just held together with...
spit and balum wire.
or cartilage.
Good intentions.
Yeah. And then slowly over time, these...
good intentions.
These good intentions form plates, and the plates grow together to form the skull.
Mm-hmm.
Yeah, it's totally...
So actually, one of the reasons why it's not fully formed is to allow passage through the birthing canal.
Oh, yes.
It can actually compress the head.
The squishiness of the brain is needed.
And the head, your head needs to be able to... That's why sometimes you'll see the parents talk about the babies came out as a cone head.
Yeah. Well, and that's why giving birth is so easy. It's because the head is squishable.
Slides right on out.
Yeah.
you ever see The Life of Brian by Monty Python?
Yes, I did.
Do you see the scene where the mom, after having so many children because they were Catholic so they couldn't use birth control, is standing there washing the dishes, and the baby just drops out?
Thwop.
So when you're first born, your skull is a little bit more malleable. I'm not saying it's soft.
Yeah.
But and the seams along the joints of the plates are not formed yet.
No, they're not.
And you can actually see this if the baby's dehydrated. We're at the
fontanelle.
Yes.
Yeah.
They can either be bulging or depressed, depending on what's going on with the child. You really don't want extremes of either.
Yeah. The fontanelle is a little soft spot that's actually located, I guess, if you were to start at the bridge of the nose and just travel your finger straight up the forehead and just kind of keep going right to where the head starts to become parallel to the ground.
Right.
That's right where the fontanelle is located.
Or the sky.
Very true. Very true. As long as you're not tilting your head.
Right.
Yeah.
Well, then it wouldn't be to the ground either.
Oh, no, exactly. Yeah. It's be perpendicular depending on how far you went.
Yeah. So, the fontanelles, like we said, those will, the suture areas of the skull, once it solidifies, those fontanelles will solidify up also.
Yeah.
Now, this is great for overall protection of your brain, but it also can hurt an overall protection of your brain. Because although your skull is now solid, so if you take a blow to said head, it is less damage. I mean, you need something there so you're not getting things sticking into your brain.
Right. Yeah, nice hard armor shell.
Right.
But there's a problem with that, though.
It now is not malleable, so you don't have any room for expansion.
Yeah.
There's no upgrading your skull.
And what we don't mean is that, there's no room for brain expansion, a.k.a. you'll be dumb. But there are some traumas we'll talk about later on where you can get blood in between your brain and your skull. And where a soft, malleable skull will give way, that's not the case. What will happen here with a nice hard skull is you'll end up squeezing your own brain.
Right. So, the bone is solid and everything. Now, on the front side of your skull, you have your face.
I mean, I have one.
Unless you're Professor Quirrell.
Who's this guy?
And then you have a face on the back of your head also.
Oh, really? That's a thing?
In Harry Potter it is.
Oh. So I clearly haven't read the books.
And we've just lost all our Harry Potter listeners. Thank you, Chris.
Or maybe we added some.
No, because I don't think if they were listening and they heard that they would all of a sudden... If they weren't listening, they would all of a sudden start listening.
Well, no, but their friends will be like, yeah, they made a Harry Potter reference. I was listening to this podcast. They're like, wait, what? Medical? Humor? Harry Potter?
Yeah, but the problem is then they'll listen to it, and you monkeyed it all up, and we just said listeners.
Yeah, and then someone's going to be like, yeah, and one of the jackasses suggested that giving birth was easy, so unsubscribe.
Exactly. Don't undo that. Don't do that.
Please stay with us.
Please, it gets better, I promise. So anyway, on the front side of your head, you have your face. You have your nasal cavities, which are big open, or not big actually, they're behind your forehead and down underneath your eyes. Inside the bone, you have what are called the linings of the brain. The three linings are, Chris?
The meninges.
Right, and they are individually called?
Mater. So you have dura mater, pia mater, and the arachnoid mater.
Right, in that order?
No, so dura mater is the outermost layer. It is the toughest one. And actually, mater I believe means mother.
Right.
And dura mater means tough mother.
Right.
You have the arachnoid space, which is a space between the dura mater and the pia mater, which is very vascular. If you were to cut it and look at it, it actually has a very spider appearance.
Just because tendrils hanging down.
Okay, gotcha.
It can look like spider legs.
Okay, cool.
But there's only 8 of them.
I don't think that's true.
I may be lying.
Okay. I don't think that's true. And then you have the pia mater, which actually I believe means petite or small mother. And that is the lining that is closest to the surface of the brain. It's right on the surface of the brain.
Right. So the human brain is the largest brain of all vertebrates relative to body size. I like how we have to quantify that statement to make us number one.
Yeah, because I believe dolphins have the biggest overall brain, don't they? Yeah.
And they don't have to they don't have to quantify that in any way.
Yeah,
they
absolutely.
Can say, no, we got the biggest.
You go on Dolphinpedia, you don't even see them brag about it.
I mean, and all they ever say to you is so long and thanks for all the fish.
Absolutely. References today, man.
And what was that referencing?
That is Hitchhiker's Guide to the Galaxy.
Actually, it is part of the trilogy and its own book.
Oh.
So
the same universe, right?
Strike 2 for Chris. So, and yes, you had me at hello. It weighs about 3.3 pounds.
Ooh.
And what was that reference? Jerry Maguire, the little boy in Jerry Maguire, is talking about the skull and the brain.
Oh, wow.
And that was a line from Jerry Maguire. You are 3 for 3, sir.
Yeah, you know what? I'm actually impressed a lot of these references aren't from the 70s. It's normally
Solid point. Well, Life of Brian.
Oh, yeah, fair enough. Well, Life of Brian's 80s, isn't it?
Maybe.
Early 80s?
No, because I think they broke up by the 80s. I don't know. So now we're questioning our own side conversation.
All right, forget about head trauma. We're actually just going to talk about this.
So, 1979.
Oh, wow. I was close.
Yeah, you were close, but so was I.
Yeah, it's true.
So the brain makes up
closer.
about 2% of your human's body weight in a normal-sized human. I'm like at 0.5.
Well, but you could have a big brain.
That's a good point, but I don't think I can make up for the ratio difference.
Cerebrum makes up 85% of the brain's weight, and the cerebrum is the... I would say, I guess that's the part of the brain that everyone's mostly familiar with. That's the most single identifying factor. And that is when you look at the brain, you see those big two halves and those kind of wiry worm-like appearance. That's the cerebrum. Contains about 86 billion nerve cells or neurons. That's the gray matter. It contains billions of nerve fibers. It's axons.
Billions and billions.
Billions and billions. And that is the nerve fibers or the white matter. These neurons are connected by trillions of connections. I want to talk a little bit about a neuron, kind of the structure is, and so why there's so many connections as opposed to the neurons themselves. So it says billions of neurons with trillions of connections. So when you're looking at this, what you see in a neuron is you have a long stick or straw-like structure. It's mostly the nerve itself, and that would be the axon that then terminates into, I guess almost it would look like... That would be hard to say, but it just sort of terminates into an end. Maybe it would look like a pinhead.
Okay.
And off that, you have these little fingers. And each of those fingers has the ability to connect to another nerve. So for every nerve, you have, 5, 10, 20 different connections that can branch off of that and connect to other nerves. So you have just trillions of connections in this amazing network.
Like all vertebrate brains, the human brain develops from 3 sections known as the forebrain, the midbrain, and the hindbrain. The forebrain develops into the cerebrum and its underlying structures, and the midbrain becomes part of the brainstem. And from what I could tell, the hindbrain was kind of your reptilian brain.
And if you look towards the back of the brain, there's sort of a baseball-sized cauliflower-type structure, and that's the cerebrum. And
Cerebellum.
No, sorry. Yeah, that is the cerebrum. Cerebellum. Sorry, yeah.
Cerebellum.
That's the cerebellum. And what the cerebellum stores is the cerebellum stores learned repetitive behavior, I believe. So, for example, like figure skaters. There's just things about figure skating that figure skaters don't think about.
Well,
They just do.
it's what people call muscle memory.
Absolutely. And that's stored in the cerebellum. And also things that you would consider instinct.
Right.
The brainstem is responsible for basically life functions, regulating respiratory rate, regulating the endocrine system to release hormones, to change blood pressure. It also is what ultimately takes the signals from the brain and transmits them to the spinal cord.
Well, the hindbrain contains many vital structures. The medulla oblongata, the pons, which is the link between the cerebellum, the forebrain, and the midbrain, and a majority of the cranial nerves, like number 3 through number 7.
And so the medulla oblongata has a lot of functions, and the pons is essentially just a wiring harness.
Right.
It just transmits from the medulla oblongata, the part that connects to the spinal cord.
Yeah.
And then it kind of sends things away. And receives as well. Yeah.
So the forebrain contains or develops into the cerebrum and underlying structures. The midbrain becomes part of the brainstem. The cerebral cortex, which will be in the cerebrum, is greatly enlarged in humans and is considered what is the seat of complex thought.
Ooh.
Yeah. Missing in some of our...
I say large in all humans?
Comparatively, I guess. Visual processing takes place in the occipital lobe near the back of the skull. The temporal lobe processes sound and language and includes the hippocampus and amygdala, which play roles in memory and emotion and respect. No, plays
and respect.
Right, and that's where it comes from. The parietal lobe integrates input from different senses and is important for spatial orientation and navigation.
Okay. I can
worked
think
with
of
some people that do not have a very well-developed sense of navigation.
Oh God, I can think of a few trainees that I've had,
Right.
and I'm just amazed where it's like, how did you get to school?
Exactly.
So yeah, brief digression. We had a guy. He did not last long. I will say, in our outfit, he turned in his resignation after the first day. Probably solid.
So not lasted long was a severe understatement.
Yeah. Probably solid. And what it was, I'm not sure how this came to be in life, but we hired him on at 21 because in our outfit you need to be 21 to be insurable.
To drive.
And yeah, to drive. And he got his driver's license specifically because it was a requirement to work for us. And so his parents drove him to the interview. He drove himself to the orientation. And then he had a valid driver's license. He was good to go. And then the next time he drove himself was...
An ambulance.
No, not an ambulance. He was in our wheelchair transport department.
Okay.
The next time was he drove himself to work to start his first shift. He was involved in an accident.
Strange.
Yeah, he was involved in an accident, and the FTO had actually was ready to stop the day early because she was so concerned about his ability to just not know where bumpers are. And she's like, yeah, I think we're going to stop our day early. They're finishing up one transport, and then sure enough, bam. And yeah, so he had his spatial navigation was poor.
Okay, so, well, I mean, that really is something that is learned. I mean, you can't just get a driver's license and go, that guy wasn't driving an ambulance. I mean,
yeah.
It's bad enough you're transporting patients in a wheelchair van, but
could you imagine
him fairly normal-sized vehicles except for height.
Yeah. Well, could you imagine him taking the cone course?
Oh, it wouldn't happen.
Yeah.
He would have been all over the cones.
Oh, yeah. The worst cone course person I ever had, and it was going to be bad. I won't go into the whole story, but this is how it started. How do I put it in drive? Ambulances are no different. I'm like, do you drive an automatic? She's like, yeah.
Like, how would you put your car in drive?
Yeah, it's like, okay, well, mine's down here, and the ones in the ambulances are on the column.
Right.
And so, and then
she was used to it being in the center console.
Yeah.
Oh yeah.
And so she goes to grab the thing on the column. While on our ambulances, you need to press the brake.
Right.
Then pull it out of gear.
In any vehicle that's been made after like 1992.
Yeah.
You have, or even earlier, you have in the last 20 years.
Well, not only, and then normally you grab, even before that though, you still have to grab it, you pull it towards yourself, and then you push it into the gear you want.
Right.
She just grabbed and started pushing towards the gears and started pushing hard. And I'm like, no.
If it doesn't go easily, then there's a problem. Don't try and force it.
She failed, because you can only,
So what he's talking about is a driving course
Yeah.
for emergency vehicle operations.
and there's a cone course, and you
Simulate a multitude of different driving conditions.
you back up, you parallel park, you zigzag, you have the serpentine. But
If
anyway,
you zig when you're supposed to zag, there's a problem.
you fail.
Yeah.
And every time you hit a cone, it adds time, and you have to complete within a certain time. So you have to complete within 4 minutes or whatever it is. And every time you hit a cone, it adds, say, 10 seconds or 15. I forget what the penalty is.
Right.
But even if you come in under time, if you hit more than 3 cones, you're done.
Right.
Took her 2 obstacles to hit 3 cones.
Yeah.
And there's 8 obstacles. So
head trauma. Head trauma.
trauma.
So anytime you hit your head, you can cause brain trauma. Now, the severity of the brain trauma will vary. So we were talking earlier about when the brain forms up. Yes, it's great for protecting the brain, but if there's any sort of swelling.
When the skull forms up.
Yes, I'm sorry. When the skull forms up. It's great for protecting your brains from blows, external trauma. But the problem is that when you do that, there's a force that's called a coup contra coup effect.
Ooh.
Right. And so this is, say you're in a car accident.
Okay.
The car stops because it hit something. Well, you will continue forward
Yeah.
because your momentum is not stopped.
Absolutely.
And this is why we have seatbelts, and this is why we have airbags.
And crumple zones in cars.
And crumple zones in cars will diminish that. Well, when your body stops, so you slide forward and your head goes and it hits the windshield, the steering wheel, the dashboard, whatever.
Or even if your head hits nothing at all and the seatbelt just stops you.
Right. Any sort of sudden deceleration.
Yeah.
Your brain does not stop.
No.
And it will slam forward into the inside of your skull.
Right.
That's the coup effect. Then, as everything goes backwards and your brain slams into the back of the inside of your skull, That's the contracoup. Well, this causes swelling.
Mm-hmm.
And depending on how bad the swelling is, you could be described as having a concussion.
Right.
Or having intracranial bleed.
Yeah. And when you have these intracranial bleeds, there's several different types. So earlier we mentioned the layers.
Right.
Those layers of the brain. And where the bleed occurs.
Real quick, I got one little thing before we move on to that.
Oh, yeah.
So when blood from trauma irritates the brain tissue, it's called swelling or edema. In this instance, it would be cerebral edema because it's in the brain. The pooled blood collects into a mass called a hematoma. Now, this doesn't just happen in the brain. If you hit your arm really hard and it swells up, it's also called a hematoma.
Right.
But inside the brain, if you have a hematoma on your forearm, you need to keep an eye on it.
Right.
Make sure it goes down properly.
But you'll probably be okay.
Yeah, chances are you're going to survive. You have a hematoma of any size inside your brain, because of the lack of the room to swell, this is a problem.
And this will cause immediate cell death.
Right.
In the brain. And depending on how much cell death it causes is going to determine the lasting effects that you're left with.
Right.
Go ahead, sorry.
I was going to say, well, the problem is that as it swells, it constricts all the vasculature around it. It presses that shut. And so that reduces the blood flow, which causes the cell death. Right.
But like we mentioned earlier, and one of the things that can cause this pressure on the brain is, of course, bleeding. And we kind of classify, we classify the types of bleeds kind of based on where they occur within those layers of the brain. In particular, we'll talk about the subarachnoid hemorrhage. So earlier we talked about those layers of the brain, the dura mater, the subarachnoid layer, and then the pia mater. A subarachnoid hemorrhage is when bleeding happens in the subarachnoid area.
Right.
And it's responsible for protecting your brain from injury by serving as a cushion. A hemorrhage in the space can cause coma, paralysis, and death. So pretty much often the result of head trauma.
So it says the condition can occur very quickly. Depending on the type of subarachnoid bleed, it can take a while.
Oh, yeah.
I've seen things where it's days later. They have trauma to their head, and they have this bleed, if it's large enough, that will make them unconscious. That we talk about, there's head pain, there's numbness throughout your body. But again, these can happen over a number of hours or a number of days, just depending on the relative size of the trauma. You get to a point where you start having confusion, irritability, which is me most of the time, double vision, nausea, vomiting, seizures. Well before you get to that point, you should probably be checked out.
And here's kind of some other symptoms, too, that you can have, which you might not immediately relate, but neck pain and then even shoulder pain.
Right.
And so you can have referred pain down into your neck as well.
Right.
That's some of the things that we look out for. And if you ever end up in an MVA, you're going to have paramedics asking you about neck pain.
Like I said, we can say this can happen very quickly. But
MVA is motor vehicle accident.
Right. So anyway, these can happen very quickly. It can also happen very slowly. I know of some events where patients had something that caused head trauma. They go to the emergency room, they get the proper treatment, and they're released.
Yeah.
And then a day or two later, they're acting very strange. So what I remember was actually when I was in college, and two guys went up to head a soccer ball at a soccer game I was refereeing. They whacked heads. You heard it from across the field.
Oh, right? God, I know that thud.
They both went down. They got up. They were walking around. They were acting okay. One guy was complaining of the severe headache. He was complaining of the shoulder, the neck and shoulder pain. So they decided to drive him to the local ER.
Good call.
ER did their evaluation. They did scans, everything like that. Well, we don't see anything. 3 days later, he's trying to feed beans into his ear.
Was he successful?
Yes. Oh. They rush him back to the hospital. They call an ambulance. They take him back to the hospital. He's got this huge bleed.
Oh, damn.
Now, did the ER make a mistake the first time? No.
Not necessarily. Yeah.
I mean, they could have done all their scans, and it just hadn't shown up yet.
Not big enough.
Right. And so, and again, this was back in the late 80s, so I'm sure the technology was not as finesse-oriented as it is today, But, so, I mean, just because you got cleared, because I hear this all the time as a paramedic, well, I just saw a doctor the other day for it, and they said it was fine. Yeah, that was the other day.
Yeah.
You're now having a heart attack.
Oh, my favorite thing is I'll get people, it's a little bit unrelated, but there are some people out there, for whatever reason, the blood pressure cuff really bothers them. They find it painful. They don't want it. But like, yeah, we take your blood pressure. Oh, I got taken to the doctor's office yesterday, and it was fine. It was this.
Mm-hmm.
Like, oh, I'm going to take it again. Why? I just got taken. It's like, well, your blood pressure is not like, it's not like you got taken 3 days ago and it's the same as it is today.
Right.
You know, in fact, that's almost true for everything you can measure about your body.
Right. All a doctor's appointment all the doctor appointment says is that you were fine at that time.
Yeah.
You could walk out of the hospital, or you could walk out of a doctor's appointment, drop over dead.
Yeah, absolutely.
You know.
I mean, hopefully not. And please go to your doctors, but, you know.
There are different things that can cause intracranial bleeds. We've been talking about head traumas. You know, taking a blow to the head from one form or another, either through, from what I've seen, car accidents,
Gunshot wounds,
falls, fights. Somebody punches you or hits you in the head with something.
Yeah.
You know, I mean, these are all things that in the moment may not seem that bad, but then down the road. And then if you add on top of that, the person is on a blood thinner.
Absolutely. And a lot of people will be on blood thinners if they have a past history of heart attack or stroke. And those are conditions where blood clots have caused a problem. And so they may be placed on a blood thinner.
For more information about stroke, see the CVA episode of Medical Stuff.
Absolutely.
It can also be on blood thinners because of a heart condition.
Absolutely. Like, for example, atrial fibrillation.
Right.
And you can actually check out our cardiac our cardiac episode
on Medical Stuff.
Yeah. Atrial fibrillation is basically where the heart, top half of the heart wiggles. And people live with this day in, day out. But it can actually cause clots to form within the chambers of the heart. And so give them a blood thinner.
And then you can be on a blood thinner because of pulmonary embolism.
Yes.
Which is clots that form in your lungs. And if you want to learn more about that, listen to our respiratory distress.
At this point, I think Mark and I are competing for plugging our episodes. And so the other thing that can also cause head bleeds is high blood pressure. And high blood pressure over time, if you think about our arteries in your brain, they're just like any other tube, like a water balloon, if you will. And if you fill up with too much pressure, it's entirely plausible that they burst like any other pipe. And this is actually what we'd call a hemorrhagic stroke, where you have a bleed that's occurring in your brain. So no trauma needs to occur. This is usually just long histories of high blood pressure that can cause this.
You can also, along with that, have an amyloid angiopathy, which is an abnormality of the blood vessel walls that sometimes occurs with aging and high blood pressure. High blood pressure is something that really, on the grand scope of medicine, I mean, everybody talks about it. I don't think people really grasp just how bad it is for your body overall. I didn't for many years.
Yeah.
I mean, we've talked on the renal episode of Medical Stuff about how it will affect your kidneys.
Yeah. And then in turn, your kidneys will affect your blood pressure. And that's just an endless cycle.
You know, and if your kidneys aren't working properly, that can cause other problems down throughout your body.
Yeah.
You know?
In fact, high blood pressure, just about every system in some way can be impacted by high blood pressure.
You can also have what's just called an aneurysm, which Chris was just touching on, where you actually have a weakening in the cell walls. You can have an aneurysm in just about any artery, or generally they're in the arteries.
Yeah, because the arteries have higher pressure than the veins do.
You can have what's called a AAA, which is in your abdomen.
Yeah, and the AAA is the abdominal aortic aneurysm, the aorta being the largest artery in your body.
Right.
And those can be, in fact, I believe it was John Reuter.
I don't know.
John, yeah, he was he was a celebrity. He was an actor.
Yeah.
He had flu-like symptoms.
Funny.
Yeah, he had flu-like symptoms for about like a week. And turns out he just had an aneurysm.
Yeah.
And unfortunately, he died.
Well, if you have a AAA or a thoracic aneurysm, he had an aortic dissection. Yeah. If your aorta bursts, unless you happen to be prepped and in surgery at the time, chance of you surviving that are nil.
Oh, yeah. I mean, it's
bleed out fast.
It's a garden hose.
Yeah.
It's the size of a garden hose that's opened up and it's just going to drain out.
And we'll probably get into that more in a future episode on the cardiovascular system.
Yes, that is planned.
So we're just plugging future episodes.
Brain tumors. That's another source that can cause bleeding in the brain.
Right. Brain
tumors, they grow. They put pressure on nearby vessels. Vessels can break.
I have run calls before where something has happened. A person's had a first-time seizure. We take them to the hospital, and they find out that is because they have one or more brain tumors. We were talking about earlier about blood thinners. Just generalized bleeding disorders like sickle cell anemia or hemophilia can both contribute to a brain bleed. Hemophilia being the fact that your body can't clot, so it's just like being on blood thinners. You know, and sickle cell anemia where your platelets are actually, or your red blood cells are actually collecting at joints or bends in their cardiovascular system. We've talked about a subdural bleed. Let's talk a little bit about an epidural bleed.
Okay.
Oh, I'm still talking.
Yes. I agree, Mark. Continue.
An epidural hematoma occurs when the blood accumulates between the skull and the dura mater. This is the outermost lining of the brain. So this is typically occurs when a skull fracture tears an underlying blood vessel. So you actually have a blood vessel leaking straight into this, between this layer and the skull itself. They're about half as common as subdural hematomas, and they usually occur in young adults. I'm going to say that's because young adults don't always make the best choices.
They do more activities that result in skull fractures.
And to back up that theory, 4 times as often among males as compared to females.
Thanks, football.
I'm not even football. I'm going to put this down to the watch this mentality of men.
Yeah.
Here, hold my beer.
Oh, I did see a funny meme out there. It said, it was swimming with kids is 50% watch this and 50% adjusting goggles.
Exactly. So now, classic symptoms of the epidural bleed will be a brief loss of consciousness, followed by a period of awareness that may last several hours before the brain function deteriorates.
And I've been on calls where this cycle has occurred within maybe 15 minutes.
Oh, yeah.
You get on scene, someone is called because someone took a spill. Actually, the one I'm thinking of is, and I swear to God I wasn't planning this. The one I'm thinking of is this guy, he had a bicycle and they were trying to recreate a scene from Napoleon Dynamite where he jumps off a sweet ramp and he's like, oh, you totally got air. Well, he biffs it.
Right.
He just entirely biffs it and he just takes a header into a parking lot, into the ground in the parking lot. And everyone's like, yeah, he kind of ride the round and stopped moving and was out of it. And by the time we get there, he's like, oh, yeah, I mean, my head hurts, but I'm all right. And then he had perseverant questioning.
So perseverant questioning.
Yeah.
Perseverant. Let's just say it one more time.
Perseverant.
So perseverant questioning is probably the most irritating thing on a call that doesn't irritate me.
But it's kind of funny sometimes.
It can be. Well, no, it's what they say and stuff like that can be funny, but the cause behind it is not funny.
Oh, certainly not.
So perseverant questioning is repetitive questioning. And these are the patients that I had so one of my first, as a paramedic, encounters with this was a guy who had wrecked his car into somebody's backyard at about 11 o'clock on a Saturday night.
Mm-hmm.
There may have been alcohol involved.
Yeah, whatevs.
All the way to the hospital. Oh, man, what happened? Oh, well, you wrecked your car. Oh, my God, is everybody okay? Yeah, it was just your car into a fence. Everybody's going to be fine. We're going to take you to the hospital and get checked out. Oh, okay. Man, what happened? Well, you wrecked your car. Oh, my God, is everybody okay? Yeah, everybody's okay, man. You just wrecked your car into somebody's backyard. We're going to take you to the hospital and get you checked out. We're going lights and sirens to the hospital.
Yeah.
Oh, man, what happened? Oh, well, you wrecked your car in somebody's backyard. Oh, my God, is everybody okay? Yeah, everybody's going to be fine, man. We're just going to take you to the hospital and get you checked out. All the way to the hospital. And that's why I say it's the most irritating thing that doesn't irritate me.
Yeah.
Because you want to get irritated because they're asking the same stupid questions over and over and over again, but you have to remember it's because they can't form new memories.
Well, remember you and I were once working a Taekwondo tournament.
Mm-hmm.
Yeah, you remember this. This guy, he got Taekwondo'd.
He was kicked in the head.
Yeah, substantially kicked.
Mm-hmm.
Mark and I actually weren't looking at the time, but we heard the crowd go, "Oh!" Yeah. And we both kind of turned. And it was one of the, so typically in a standby event, especially a sports event, you wait for because they usually have their own doctor, sports doctor, sports medicine. You wait for them to kind of wave you in. Mark just walked out there because it was very clear that this guy needs a medic.
And he was down.
Oh, yeah.
But he was awake when we got to him.
Yeah.
We got him off the floor.
He's like, I'm fine.
Yeah. Then he started repetitive questioning.
Yeah. Well, because Mark just came because I was sitting down at a med tent or a desk or something. And so Mark's just like, Mark went out there, brought him back out and was like, tells me what happens. Just like, just keep an eye on him. Then later on, I'm like, so I'm talking to the guy. And this is actually something I picked up from Mark at the time, was give them 3 things to remember. Mm-hmm. I'm like, hey, my name is Chris. Remember the number 3 and the word fire truck. You got it?
Those are mine too.
Yep. Well, I learned it from you. I stole it from you. And he looks at me and he goes, all right, Chris 3, fire truck. I'm like, perfect. And then a little bit, we're kind of having the same conversation, but not quite. I'm like, hey, what were those 3 things? He's like, gosh, I don't even know if dinosaur? I'm like,
right.
Hey, Mark.
We got a problem.
I think we have a transport.
Yeah, and we end up taking them in.
Yeah, we did.
So, yeah, the perseverant questioning is not good.
Yeah.
It's not good at all. But then you have further along down the path where you start having the seizures,
Yep.
unconsciousness, and then you get to posturing.
Yeah. So posturing is something that can occur. It's kind of a late sign, but
It's bad.
yeah, posturing is a sign of increased intracranial pressure, and that's from that bleeding that's going on.
And there's two kinds.
So, go ahead.
There's decorticate and decerebral posturing.
Yeah.
And if I remember correctly, and this was a long time ago from paramedic school, decorticate is worse than decerebral.
So that is actually, so one of the things that I did when
Oh, God, you're one of these new medics who knows everything, aren't you?
actually I can't even say I'm new anymore. It's been 10 years. Like it's been a decade, Mark. How long has it been for you since school?
So they're both bad.
Yeah. So they're both bad. And so, yeah, it used to be where what they were saying was that discorticate was worse than decerebrate. But a lot of physicians had pointed out, because, well, I'll explain what's happening.
I think it's a degrees of really bad.
Yeah. Did I?
No, I'm saying really when you get down to it, you're kind of, it's like saying a gunshot wound to the chest is worse than a gunshot wound to the abdomen.
Yeah.
It's still a gunshot wound to your body.
Yeah. Basically what it came down to is, what at the time I was in school, is that the difference between them is negligible.
Yeah.
In terms of they're both so far down, and they may not happen in order. So let me explain kind of what's happening and why that occurs. So as your brain, as the pressure inside your head starts to increase, it starts to push the brain, and the brain's going to start finding a hole to go down. There's one hole in the skull that it's going to go down, and it's called the foramen magnum, and it's just a big hole at the bottom. You didn't think I knew that word, did you?
No, every time I hear it, I think it sounds like a Swedish or Icelandic name.
Oh, yeah.
Hey, Freeman Magnusson.
Oh, yeah, there.
And we apologize for the impressions.
There's probably some guy named that's like, damn it.
He now knows where his name came from.
No, there you go. It starts pushing it down this hole. So earlier we talked about...
That's not built to take things through it.
No.
From pressure.
Not at all.
It's where your brainstem actually goes down to your spinal cord.
Yeah. And so as we talked about earlier, the brainstem is responsible for certain body functions. Mm-hmm. And it's responsible for...
Pooping.
It's responsible for releasing hormones, stimulating other organs to release hormones to regulate blood pressure. Mm-hmm. It's responsible for respiratory rate. And so what you'll see is something we call Cushing's triad. So as the brainstem gets shoved down this little tiny hole, you'll see a decrease in heart rate. Mm-hmm. And that comes from basically crushing something called the vagus nerve, which is one of the cranial nerves, but it goes through the brainstem. Mm-hmm. You'll see an increase in blood pressure, and you see the increase in blood pressure because as the brain's getting squeezed, it feels that it's hypoperfused, meaning it's not getting enough blood. So then the brain will send signals to do things such as vasoconstrict, which means the pipes, all your arteries and your mm-hmm. veins constrict, and that'll raise your blood pressure. But also because we're crushing the brainstem, which helps regulate respiratory drive, you start seeing irregular breathing patterns as well. Mm-hmm. So that's called Cushing's triad. Buyouts breathing or Shane Stokes.
There you go.
Those are the two common ones that occur.
Take that, Spencer.
Yeah. If you've listened to our Medical Myths episodes where Spencer Oliver joined us, thank you, Spencer.
Mm-hmm. Hashtag Science Tiger.
Hashtag grass. But we bring up that breathing thing because Spencer Oliver, he's also a listener. And we really appreciate that of him, but he has pointed out in a past episode mm-hmm. where we, which one
used the wrong term where he said Koosmalls.
Yeah, we said Koosmalls, and he called us out. He was right.
He was right.
He was right.
Still mean.
But also, so as the brain swells, what will eventually happen is that, like we said, like messages for motor function are also sent down the brainstem as well. So as the brainstem becomes more and more compressed, what you'll also start seeing is erratic motor movement, those being discorticate and decerebrate posturing. Corticate is where you have the limbs are curving in towards the core, and decerebrate is where you'll actually have them kind of flaying out and away from the core. So which one's worse than the other? It's difficult to say.
It's a degree of really, really bad.
Because your brain's being pushed down a hole. Maybe it's not being pushed down evenly. So maybe your brain's really far down that hole, but for whatever reason, you're getting decerebrate posturing. Mm-hmm. And you'll never see discorticate posturing.
We had a autoped. So it was a person hit by a car. we get there. This is one of those calls where you pull up on scene, and from the front of the ambulance, you're like, oh, that's bad.
Oh,
This is not good. So we hop out, my partner and I.
like get the broom not good? Or?
No.
Okay.
Like, I'll go to the patient. You go get equipment.
Gotcha.
You know, we show up. Fire department's not too far behind us. I go to the patient. This guy was skateboarding on a road at 1:30 in the morning, got hit by a car.
Okay.
He's out. He's unconscious. One pupil is exceptionally large, and the other pupil is constricted.
That's a bad sign.
That is a bad sign. This is posturing bad, right? My partner went and grabbed a board, and I got to tell you, kudos to my partner. He kind of tossed it at me from a distance because he's grabbing other equipment.
The board he's grabbing, by the way, is a backboard.
A long spine board.
Yeah, it's a splint
And it
essentially for the
slid
spine.
to almost a perfect position right beside the patient.
Awesome.
I mean, right way around.
Please tell me your partner then just goes, nailed it. And then
No, he was already walking back to get more equipment.
that's extra nailing it.
Yeah.
You're so good at throwing that you don't even care what the result are because you what the result is because you know.
You don't care, you just know.
Yeah, exactly.
You know. We had a 5-minute scene time with him.
Good.
We rolled him onto the board.
I'd have done it in 4 minutes, but
Whatever. We rolled him onto the board. The fire department were like, okay, let's get C-spine precautions in place. We're like, nope, let's go. We held manual C-spine. I took some fire riders. One of them just worked on finishing up the C-spine on the way to the hospital. My intern held C-spine the entire way. We dropped a tube on this patient while en route. We got to the hospital. They did a spinal tap on this patient. They're checking because the brain is pushing down through the hole, it increases the pressure of the spinal fluid in the spine.
That makes sense.
So normal spinal fluid range, like 5 to 10, I believe it's centimeters of pressure.
Okay.
115 on this guy. Yeah, he did not make it.
Yeah, that's too bad.
Yeah.
Dropping a tube, by the way, is it's intubating. We basically place a breathing tube in their trachea, and we like to do that on head traumas because vomiting is a very common response the body has to head trauma, and the last thing you want is vomiting in the airway.
Also, as part of the whole posturing and everything else and the seizures, they can clench their jaw shut. So if they clench their jaw shut and they start vomiting, you can't clear that airway.
Or if they're bleeding in their airway. I mean, if you have head trauma in the first place, bleeding
hemorrhaging.
Yeah, bleeding can be a next step, and you'll get a lot of blood in the airway as well.
Yeah.
Do you want to talk about some head trauma treatments?
Sure, why not?
So there's a surgical intervention called the decompression surgery. This relieves pressure on the brain and allows a skilled neurosurgeon,
As opposed to the unskilled ones working on you?
absolutely. You know what? If you can tell me you're a neurosurgeon, I'm going to say, you know what, skills. That's pretty good. I mean, not like throwing a backboard from across the scene skills.
No, I mean, those are life-changing skills. But,
Yeah,
I mean,
absolutely.
sure, you can poke around somebody's noggin, fine.
Okay, tell you what, if they can poke around in the noggin and then just turn around and walk away without really seeing the results, just like your guy did, that's fine.
Yeah, that's obviously equal.
Yeah, but basically what this is they remove the pooled blood, that blood that we talked about that's crushing the brain, and they're actually able to repair damaged blood vessels that are actually leaking. Evacuating the hematoma immediately relieves pressure on the brain, and it reduces the size of or the amount of the pooled blood. Pooled blood from the bleed.
So now decompression surgery is not a particular type of surgery. That's a general header for the types of surgery we're going to be talking about here. So all of these are decompression surgery, right? So, and again, it says here multiple times, you have to be a skilled neurosurgeon.
Yeah.
Apparently if you have all thumbs, you just can't do it.
Could you imagine? One of the things that Mark mentioned earlier is that, and we've mentioned a few times, that when you start bleeding in your brain, that firm, hard skull that was so good at protecting you from a baseball bat starts to kind of work against you.
Right.
And so one of the treatments for increased intracranial pressure is going to be what they call a skull flap. So this is a surgical intervention where they literally cut a flap into your skull, and that allows the brain to swell a little bit more and displace.
Also to keep in mind, sometimes you may have a brain bleed that's small enough they just won't do anything for it. They'll watch it. You'll spend a couple days in the hospital, and they'll wait for it. Because, I mean, before they do really any of these surgical interventions, they want to make sure there's a damn good reason.
Yeah, because as you can imagine, exposing the brain is a dangerous procedure.
You ever see that commercial with he's doing brain surgery, and he's got things in the guy's brain, and he's using them to check different websites for travel.
Yeah, that's and then at the very end he high fives somebody. That's a good commercial.
That was. So yeah, so you may have a small brain bleed and they may not do surgery on you. That's good.
Yeah.
That's a positive sign, And then they may be able to treat you with different medications, diuretics, stuff like that are very common to be used. Common things can be used, medications to be used because it decreases your fluid level, thereby decreasing pressure. Now, again, these are mild to maybe moderate symptoms or brain bleeds. Mm-hmm. Then once you get to a certain point, they have to go in and intervene surgically. The neurosurgeon, doesn't have to be skilled apparently, removes a portion of the skull. So they'll actually take out a section.
This is really the preschool.
Kind of like repairing drywall when you put a hole in it.
I don't think kind of like, I think exactly.
In fact, if you can do drywall,
yeah, don't
do brain surgery.
I'm actually pretty good at patching drywall.
Are you?
Yeah.
Tell you what, hit me in the head with a hammer and we'll check it out. See if it's comparable.
Yeah, no, I got a hammer. I'll be right back.
So they remove a portion of the skull and conduct open surgery to drain a hematoma and repair the ruptured vessel. So the advantage of this is they can actually get in there and repair damage that's been done on the vessels, which will stop the bleeding. This is major surgery that's typically used when the hematoma is very large or when it's compressing the brainstem and where critical functions are controlled. So, yeah, this is bad. If you have to have a section of your skull taken out.
Yeah.
So, simple aspiration. I like how the word simple is in there. Because, any unskilled neurosurgeon apparently can do this one.
No, absolutely.
Yeah, it's just a simple aspiration.
Oh, my son could do it.
Yeah, we're just drilling into your head.
My son could do it. He's 5.
The surgeon drills a small hole into the skull and drains a hematoma using a needle. Because that's what you want in your skull, a needle. This is a relatively non-invasive procedure, but it can be difficult due to making sure you're in the right spot before you start drilling. Kind of like looking for water with a divining rod.
Or back to drywall, finding a stud.
Exactly. You just really don't want to run into these unforeseen problems.
Do you think they use like a stud finder? Like they just have this thing going over the patient's head? It's like
beep, 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 beep. Yeah.
Grab, get a new from Home Depot.
Exactly. Batteries. I need batteries. 2 AA's. Thank you. But it doesn't, if you're not kind of really spot on with your hole drilling, you may not be able to get rid of the entire hematoma. So then you have endoscopic evacuation, which is similar to the simple aspiration, that it involves drilling a hole in the skull, but instead of traditional surgical instruments or a highly skilled neurosurgeon, so you really got to bring in your A squad for this one, can reach and drain the hematoma using an endoscope, a tiny camera-guided instrument.
Yeah, and this is not your Craigslist temp agency neurosurgeon here.
No,
this is...
You need references.
Yeah.
Written references with phone numbers.
Yeah, you have to go to a real school.
Exactly.
Yeah.
Can't go to just Bob's School of Neurosurgery.
God, I hope there's actually a Bob's School of Neurosurgery out there. That would just...
I'm sure we'll hear from them.
Yeah, exactly.
Sir, but we're an accredited university.
I'm going to charge them for advertising.
Exactly. Then you have the stereotactic aspiration. This is where they use CT scans or computed tomography to locate the hematoma and to specifically develop suction tool to drain it. The patient's immobilized to a stereotatic head frame that allows greater degree of precision. So I believe these are the patients where you go into the surgery center and they actually have the CT or the constant MRI, and they can actually watch what they're doing through the CT to make sure they go to the right spot. And I believe that they've also expanded the ability to do this to their now. This is one of the things that they do for taking care of hemorrhagic strokes.
Oh, wow. Okay.
Have you transported one of those patients? I've done it twice, and they're for stroke patients that have come in from an outlying area by airplane, by medical flight.
Okay.
And they're usually a code 3 run back to the hospital from the airport and straight into, we went to, from our gurney straight into CT, so the hospital could get one of their own CTs for just updated. Then we took them straight into the surgical suite where they have the real-time MRI CT where they can run it while they're doing the surgery.
Wow.
Yeah. First time doing it, we walked in. They had a whole bunch of stuff covered in blue. As we go through the door, the person goes, "Don't touch anything blue. It's sterile field."
Oh, but I like blue.
So we're going in, removing the patient around. I see my partner, and I go, "Don't touch anything yellow, or don't touch anything blue." I am colorblind, so
if that is what you actually said.
No, I said, "Don't touch anything blue," and he goes, "Okay." Moving straight towards a blue sheet.
Stop!
I go, "Don't touch anything blue," without the hiccup. So don't touch anything blue. He goes, "Okay." I reach out, I grab him by the shoulder and stop him. And I go, "Look to your right. Don't touch anything blue." Sorry. We moved the patient over. We're getting the gurney out of there. One of the nurses walks by. She goes, "Thank you," because we would have had to have gone to the other surgical suite. Once he touched that, that would have been the end of this surgical suite till we could reclean it.
Wow.
Yeah. Don't touch anything blue.
Boy, that would have been a faux pas.
Right.
So the final one here, and I've had a few patients that actually have these in, is a clipping or coiling procedure. It's maybe appropriate if the intercerebral hemorrhage is caused by a ruptured aneurysm. So what this is it's literally a coil. So an aneurysm, like we had said, is a weakening of a blood vessel. The wall thins out, it kind of balloons out, and it can burst or rupture. Well, one of the things that we can actually do, not we as paramedics, but apparently skilled neurosurgeons.
Hold still, sir.
Yeah. Goes in through the ear, right?
Right.
Yeah. One of the things that can be done, though, is it's a coil that essentially just wraps around the outside of the affected artery and strengthens it up. If you think, a good way to think of it is if you look at or how it looks, if you look like some of your charge cords where they have like a spring wrapped around the end of the charge cord, it's kind of the same deal. You just take that and they wrap it around. It's
probably the same material, too.
Yeah, they're probably just salvaging them off charge cords.
Right. That's why charge cords cost so much these days, because all the hospitals are using them for cheap things.
Them up.
Yeah, exactly.
Yeah. We just got to hope that the artery that's burst is the same size like an iPhone charger.
Pour some whiskey over it before they put it in to sterilize it.
There you go. and that's probably your Craigslist Bob's Neurosurgery School guy right there.
Unless there is actually a Bob's Neurosurgery School, at which point you're a fine institution. We are not slamming on you. This was done for comedic effect.
Oh, God, I can just imagine somebody. All right, get the whiskey. Give me one of them old charge cords. Pull a little spring off there.
Slap some whiskey on there. Give the patient some whiskey to, help deaden the pain.
Give me the good chisel.
Right.
Yeah.
So, head trauma bad.
Yeah. I think the only thing I want to talk about really quick is one of the tools we use for an evaluation of head trauma patients as paramedics. It is used throughout the hospital. It will be something called the Glasgow Coma Scale. So the Glasgow Coma Scale, I can't get too in-depth to it because if we explained why each category is the way it is as we went through, we'd be here for another episode. But the Glasgow Coma Scale is a tool that we use that the score can range from 3.
Didn't we talk about Glasgow Coma Scale in the EMS paramedic story time?
I think we
I remember us talking about Glasgow Coma Scale.
I almost want to say it's more recent than that, but we didn't really touch on it a whole lot.
No.
Yeah.
So where was it made?
It's from Europe in
Glasgow.
Maybe?
The answer's in the name, Chris.
I can't remember where Glasgow is, though. Scotland. Okay, gotcha. So it's a Glasgow Coma Scale, and it comprises of 3 categories. And you combine the scores from these categories to get a rating between 3 and 15. You can't go below 3.
You get 3 just for showing up.
Your phone has a GCS of 3. Your phone actually, nowadays, your phone actually might be a little bit
great. So it beats me on GCS and on IQ.
Yeah, right. Exactly. So the first category is eyes. The best you can do in the eye category is a 4.
And this is not like an iPhone.
No, it's the eyes on your head. So if your eyes, they call spontaneous eye movement. That means the person's eyes are opening, they're tracking people that are coming in. It's appropriate usage of the eyeballs. That gets you full points. That's a 4. So, yay, you get a 4. If you're...
Appropriate usage of the eyeballs.
Appropriate usage of the eyeballs, yeah. I'm not wrong.
Right. No.
But you lose a point if you only open your eyes to verbal stimulus.
Right.
And then you lose another point if you only open your eyes to painful stimulus. If you don't open your eyes or your eyes are fixed.
1 point.
Yeah, you get 1 point. So if your eyes are fixed just staring forward, 1 point.
Or closed.
Yeah, or closed. Yeah. So next up is verbal. So verbal, you can get 5 points. If you're speaking appropriately and everything's fine and you're not confused, you get the full 5. If you're confused, or another thing would be perseverant questioning, that would drop you down a point. So you're going to get the 4 points. After that would be inappropriate. So I understand what you're saying, but it doesn't make sense. Like your apple basket water bottom. That doesn't make any sense. That gets you 3 points.
Tongue is quite the mental image.
Well, yeah, it
basket,
does.
Water bottom. Right. Well, I mean, if you're not answering the question that's asked,
yeah,
that's
inappropriate.
Hey, how are you doing today? Boogers.
Yeah, that's inappropriate. Incomprehensible is the next one.
Incomprehensible sounds.
Yeah, and that's just kind of blah, 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 or I call it the trauma scream, where you'll get these people kind of do this cyclic screaming almost. And then, of course, no response is 0 points. Or not 0 points, sorry. No response is 1 point.
Right.
You can't get 0 points in any of these.
And the last category is best motor response.
Yeah.
So it's 6 points if you obey commands. 5 points if you move to localize pain.
So like if we start an IV.
Right.
And you're like, ow, and you localize that pain, like
you
where
try
it's
and pull away or you reach over towards it.
Yeah.
And this is all these categories are based upon that you're not achieving the higher scores.
Right.
The highest point you get is you localize the pain. Then the 4th point, for 4 points, you flex withdrawal from pain. So this is where, as opposed to localizing the pain where you acknowledge the pain, flexion withdrawal from pain means you actually pull away from those things. So if somebody tries to start an IV on you and they actually pull away from you, they flex away from it.
And you actually might have more like I would almost call it like a nonsensical or global flexing. So for example, you poke the IV and then both the patient's arms withdraw back in. Well, it doesn't make sense for the left arm if it just hurt the right arm. You know?
So for 3 points, you get abnormal flexion, which is the corticate. And then for 2 points, you get abnormal extension, which is the cerebit. Yeah. So by that standard, I guess I had them backwards earlier because I said the corticate was worse than the cerebit.
Oh, okay. And then, of course, if you have no motor response whatsoever, 1 point.
1 point. 3 points for showing up. So your best response is 15 points. A comatose client would be 8 or less.
Yeah. And we see, I mean, I'd say the most common GCS scores we see are obviously 15 is probably the most common. But it seems to be either, for me, it's either 14 or 3.
Right.
Like that's where it kind of tends to end up a lot of the time.
Well, and that comatose patient comes, this is something that, so Chris and I have certain words or phrases that drive us crazy.
Oh, yeah.
And they're different, a little bit different for both of us. Some of us share some. One for Chris.
Definitive airway.
I was going to go with black ice.
Oh, yeah. No. Okay, go for that one.
It's a good way to make Chris twitch.
Here's my problem with black ice.
Which has been we've gone over in other episodes.
Oh, we'll go over it again. You brought it up. You knew it was going to happen. Here's the thing. It's not that I don't think black ice exists. There is ice out there that is difficult to see. I get it. But every time I go on an MVA where some skilled practitioner of driving has managed to crash, it's always the same thing. Oh, it must have been black ice. It's summer. No, but it's
84 degrees out here.
Yeah, but no, it's always, it's black ice. And it's just like, no, it's not.
Well, they use it as like this mystical thing that they couldn't have overcome. There was no way anybody could have predicted there'd be ice out this morning.
But I'll be the first person to point out, be like, sir, 200 people have gone through this intersection. One of them is in the telephone pole.
Right.
That's you.
You're overdriving the situation.
Or my favorite thing is it's kind of like, well, you didn't see the ice. It's like, well, yeah, but I just thought it was water.
It's below 32 degrees out today, ma'am.
20
or sir.
20 degrees out.
Right.
It can't be water.
Right.
There's no physical way it's water. it is frozen.
So in this instance, it's the phrase, "Less than 8 intubate."
Oh, yeah, I've heard that too.
Basically, if you have a less than 8 Glasgow coma score, you have to intubate this patient.
Yeah.
The reason I don't like this is I hate anything in this industry, emergency medical services, where it's an absolute.
Yeah, there's no black and white in this job. There really isn't.
There's a lot of gray areas.
Oh, absolutely.
Now, I've had patients that were above an 8 that we ended up intubating.
And had them below an 8.
Had them below an 8. I also had patients that were below an 8 that I did not intubate.
Yeah.
I had a patient that was a 3. And that's one firefighter really, really, really wanted to intubate this lady. really did.
Wow.
To the point that I was first on scene. I was PIC. I said, okay, we ready to go? He looked at another firefighter, goes, do you want to intubate before we go? And I said, no, I really don't. And I told my partner, said, DJ.
No.
And we picked up a patient and went to the gurney from between these two guys. I'm like, now in this instance, she wasn't actively vomiting.
Mm-hmm.
That's our biggest concern in these patients. They're going to start vomiting and aspirating, which is where you breathe it into your lungs.
Yeah.
The problem I had was we are 3.5 minutes from a hospital. I'm not going to sit on scene with a patient for 5 to 10 minutes trying to get a line, get the medications on board to tube the patient, actually tube the patient when I can be in a hospital in 3.5.
Right.
And so this was not a trauma, so I didn't have to go to a trauma center. This was medical. She had an aneurysm.
Oh, damn.
Yeah. A very healthy 37-year-old female that ran. Was
Wow.
a runner.
See, that's why I don't run.
Exactly.
Yeah.
It's deadly.
Yep.
So, okay, so that's the Glasgow Coma Scale. This is head trauma. Anything else you got?
No, man.
So, we are Medical Stuff. We're on Facebook. We're on Instagram at Medical Stuff 52. And we're on Twitter at Medside Stuff.
You can also email us at medscistuff@yahoo.com. You can check us out on Google Play and iTunes, Stitcher, and now Spotify.
Also on Spreaker or Spreaker, depending on how you want to pronounce it. And yeah, hopefully on iHeartRadio soon.
Yeah, it could be by the time you hear this episode, we're on iHeartRadio.
Yeah, we're just waiting on them to get back to us.
Right.
So I think that's everything, and you'll have a good evening and toast.